Hi, I'm Lawson Keppel. I'm with Virginia Harm Reduction Coalition. We are a harm reduction agency that operates in Virginia and Southern West Virginia, and wanted to talk to you today about the program that we had, thanks to Prevent Cancer Foundation, which is addressing Hep C, which is a rising problem in folks who inject drugs, which is the highest transmission rate right now for Hep C. Next slide. A little bit about us. Virginia Harm Reduction Coalition, as I said, we operate in Virginia. We have an office in Virginia Beach and in Roanoke, Virginia. Our mission is to improve the health of our friends, really. And we do that by shifting resources to the folks who have intentionally had those kept from them. A lot of that is folks who use drugs and the paraphernalia laws that prevent folks from accessing the sterile things that folks need in order to not transmit Hep C, HIV, give them in other infections. Let's go to the next slide. So a little bit about our services. We have a day drop-in center, which a lot of folks who don't have houses come in and use, charge their phone, take a nap. In addition to that, we have wraparound services, benefit enrollment, overdose education, HIV testing, and peer support for folks. So what does that look like? We just wrapped up 2020, and I have some of that data here. We have 1,200 people enrolled in other services. We got 42,000 doses of naloxone out. And you see the test results there for Hep C, and we'll talk a little bit more about that program in a minute. Next slide. So what does Hep C treatment have to do with cancer prevention? When we look at hepatocellular carcinoma, we're looking at a pretty deadly cancer. 2-year mortality rate at 50%, 5 years at 90%. The reason why we want to focus on Hep C is because the transmission rate, or the transition from hepatitis C to hepatocellular carcinoma is 17 times more likely for folks. Of course, we talked about the population with the highest rate of hepatitis C, and that is currently people who inject drugs. It's the number one transmission rate. And when we look at the other reason to do this, when we look at the modeling with hepatitis C, as long as we can get medication-assisted therapy and wide coverage syringe programs and antiviral treatment, we can cut rates of hepatitis C from 50%, and I've seen it as high as 80%. Wanted to talk specifically about our location. It's top left there, you can see the hepatitis C burden throughout the state. And as you see here, the largest burden is in Southwest Virginia. Roanoke City, where we're based, has about a 350 per 100,000 rate. I believe the rest of the state has something close to 20 per 100,000. So it's obviously a burden in the rural areas. Below that, you can see instances of infectious diseases and where they rank in the state. It's probably pretty hard to read on the right there, but the top line is hepatitis C. Has been, always will be, and we can address it with a comprehensive approach. Next slide. So what are the results of what we accomplished? So we went through and had community pop-up events, had folks in the office during our outreach, and did the rapid hepatitis C tests. We did about 322, which was, I think, about 100 less than we had submitted for the program. And we'll talk about the reason why we didn't hit the number in just a second. About half of those folks had Hep C or were reactive to the antibody test. And the reason why that's lower than some of the citations in the prior slide is because we hosted community events where folks who weren't necessarily part of the people that we serve were coming in to get tested, and we welcome that. We, as I mentioned, we had 1,200 people enrolled in VHRC services. We were able, with each touch point, we talk about transmission and ways to reduce harm. Obviously, we're a harm reduction program. And so part of the materials that we transfer those folks is education, and that's a big part of it. In fact, I think the most common question I get about Hep C is if I can give it to myself. And that question sounds silly, and it is naive but the reason for the question is it's so ubiquitous in the community. People just think you develop it from injecting. So getting folks into treatment proved difficult due to COVID-19. We had 12 folks make the first hepatitis C clinic. I think the first 2 hepatitis C clinics. We hosted one in the New River Valley and one here at our office in Roanoke. As you can see, the drop off, we had about a 50% completion rate, which honestly isn't bad. Trying to work with our folks can be tough. Most of them don't have phones. If they have phones, they probably don't have minutes. If they don't have minutes, they probably don't have access to a Wi-Fi source where they can get through that. So that, I think, played into our ability to get folks into treatment. In order to open up the treatment capacity that we also found when trying to get folks into treatment, we helped found the Virginia Hepatitis Coalition. It's a group of folks, medical professionals, community health educators, people who use drugs, who are setting about to look at the systems that we have in place to look at developing and building capacity to treat and screen for HCC and hepatitis C. So that's a big part of this program coming out of it, was getting that capacity, because capacity stuff. We have folks who wait, I think they're told to wait 6 months before they'll be able to get into the clinic. All right, next slide. There's my contact information. I always say, we love you, be safe, carry naloxone, and look forward to talking to you and answering questions.
Hello, I am Mansi Jayaprakash, Program Operations Director at the Center for Asian Health Equity, University of Chicago. I am representing our team today to present on one component of our programs where we established timely linkage to diagnostic colonoscopy through technology solution. I am extremely thankful to Prevent Cancer Foundation for providing this platform to present our work. At the outset, I have no relevant financial relationships. Our technology solution is part of 2 funded programs two ongoing programs that are funded by the Centers for Disease Control and Prevention's Colorectal Cancer Control Program and the National Cancer Institute's Moonshot Initiative. We were also previously funded by the Prevent Cancer Foundation for this work. Now, we all know that the burden for colorectal cancer is real, with colorectal cancer being the 2nd leading cause of cancer deaths. You can see some numbers here on the new cases, on the estimated new cases and deaths in 2021. The most important fact is that screening for colorectal cancer is effective. There are several screening modalities which pose both a challenge and a success. The success is that some tests, like the stool-based tests, can be performed in the convenience of patients' homes. However, the challenge is that abnormal stool-based tests need to be followed up with timely diagnostic colonoscopy. Now, screening is effective when started early and when the loop is closed. Now, in fact, 9 in 10 cancer deaths can be prevented. Yet, 23 million individuals have not been screened, and 85% of them are actually insured. And we know that the pandemic has had a detrimental effect on colorectal cancer screening, with closures of GI units or gastroenterology units for elective procedures in the early months of the pandemic. Now, it's estimated that there will be additional 4,500 additional colorectal cancer deaths due to the pandemic. Now, because of the pandemic, we not only have these millions of individuals who have not been screened, but we also have additional individuals who've missed screenings and who have delayed diagnosis, thus really amplifying the burden of colorectal cancer. Now, when we look at colorectal cancer screening status across the United States, we see that Illinois state is in the last quartile for colorectal cancer screening. Within Illinois, there is significant regional variation, with many rural counties below state average. In fact, southern part of Illinois extends into the nationally designated colorectal cancer mortality hotspots. There are only 3 hotspots across the nation. Now, in Cook County, which is the top right-hand corner of Illinois, that is home to Chicago, we see a high incidence of colon cancer here, despite the abundance of hospitals providing specialty care, and also the high density of community health centers, as seen by the distribution of red and blue that represent both hospitals and federally qualified health centers. As incidence is also high, concurrently, the screening rates are below state average in Chicago. While access to care contributes to low screening rates, the inability to fully utilize existing healthcare resources accentuates the problem. Several of our health center partners are unable to track patients once a referral is made. They're unaware that majority of their patients with the referral did not make it to a procedure. And even if patients completed procedures, they did not receive reports back in a timely manner. Now, this problem can be visualized across the different levels that contribute to a fragmented healthcare system. At the provider level, poor communication between providers and specialists can lead to delays in diagnosis, medical errors, and unnecessary testing. At the patient level, we know that stool-based screenings are effective when abnormal stool tests are followed up with timely diagnostic colonoscopies. The reality is that 50% of referrals fail to result in a procedure, and no point of service specialty care scheduling leads to failed screening. This in turn leads to unfilled capacity in hospitals, almost to the tune of 24% unfilled procedures in GI units across the country and across both urban and rural settings. This is simply missed revenue for hospitals. And this repetitive pattern of fragmentation has grave societal consequences. For our example here, that would be called colon cancer. And we are here to disrupt this pattern. So we developed a solution, a technology solution, the Illinois ColonCares.org portal, as an end-to-end solution to link patients to colonoscopy services in partnership with staff at our community health clinics. This really stemmed from our community health center providers not wanting to screen their patients since they had no mechanism for follow-up care. Our innovative team then, back in 2017, developed the web-based portal that's HIPAA compliant. The portal connects out-of-network health systems for ease of communication between providers, enables scheduling and access to quality care. Now, how does our solution work? It all starts with hospitals allocating slots in the web-based portal to fill their capacity. The clinic staff are able to log in to the portal when the patient is available with them. The clinics can then see the availability of several slots and schedule patient appointment before patient leaves the clinic, thereby providing point-of-care scheduling. Patients are then walking out with appointment time along with instructions on prep and the colonoscopy procedure. Meanwhile, the hospital gets to confirm the patient within the portal without the need for fax or phone and with the ability to communicate within the portal. The patient then completes colonoscopy at the hospital to reduce colorectal cancer risk. After the procedure is completed, hospital then uploads the reports on the portal and clinics receive their patients' results, including quality benchmarks, thus closing the information gap and also sharing quality metrics. While the patients in the hospital side, the clinic is able to visualize at what stage of completion the patient is at. Thus, they're able to track their patients. So the portal enables out-of-network communication and also bi-directional communication. So our impact is measurable. Our solution has contributed to early detection. Of the completed patients, 44% of them had precancerous polyps that were removed. Now, almost all of them had good bowel prep. There was only one no-show patient during the pilot phase. The pilot phase started in 2017, and we have expanded the portal over the last year. 85% of scheduled patients completed their exam. Now, it's 85% and not 95% because of the pandemic, where several procedures were canceled and rescheduled. For all the patients scheduled, 90% of them were uninsured, thus meeting the critical need of access for our vulnerable patients. One of the uninsured patients was diagnosed with stage 1 cancer, and they were able to get cured. Wait time for these uninsured patients was reduced from 18 months to less than a month, thus contributing to early detection. Now, all participating clinics are either federally qualified health centers or free clinics in Chicago. We are excited to roll out our technology solution with rural partners this year. We have learned that building on existing relationships between clinics and hospitals or neighboring hospitals is important in ensuring successful implementation of the solution. So this is our innovative team implementing our technology solution. So thank you for listening. And that concludes my presentation.
Hello, I'm Shelley Dusick, current chair of Mountains of Hope, and I have no disclosures. Nationally, West Virginia now ranks second for new cases of lung cancer and third for lung cancer deaths. Lung cancer kills more people in our state than breast, colon, and prostate cancer combined. Each year, it's estimated that more than 2,000 people will contract lung cancer, and over 1,400 West Virginians will die of the disease. Of those diagnosed with lung cancer in our state, more than 74% will be diagnosed with regional or distant metastasis. So imagine our excitement when the USPSTF released their first lung cancer screening recommendations in 2013. Finally, we had a way to detect this disease early. Armed with new guidance, we knew there would still be barriers to overcome. Experience told us that just because lung cancer screening is possible does not necessarily mean it's available to those that need it most here in West Virginia. That's where Mountains of Hope Cancer Coalition comes in. We knew that with 20 years of collaborative work experience, the coalition was perfectly poised to introduce lung cancer screening to the Mountain State. Mountains of Hope is West Virginia's statewide cancer coalition. The coalition is composed of individuals and partner organizations who work to reduce the human and economic impact of cancer. Our members include state and local governments, private and nonprofit organizations, health, medical, and business communities, academic institutions, researchers, cancer survivors, caregivers, and advocates. Mountains of Hope is also the author of the state's cancer plan, and lung cancer screening was prioritized in the 2016-2020 West Virginia Cancer Plan. This allowed the coalition to establish a dedicated work group focused on developing lung cancer activities for at-risk West Virginians. Since coalition members self-select which group they choose based on personal passions or organizational goals, this gave us a dedicated and connected base to carry out the work. While many of the people needed to roll out this new cancer screening initiative were already at the table, this was not a task we could do alone. Coalition lung cancer screening activities engaged more than 297 partners, including 13 member organizations, 47 media outlets, the governor's office, community groups, and over 200 healthcare personnel, which includes lung cancer screening facilities and primary care providers. Armed with motivated volunteers, the new USPSTF lung cancer screening guidelines, and an urgent need, the coalition was ready to do something, but had no idea of what that something should be. We started with a blank page, and we asked these two questions. What do we want to do, and how do we want to do it? Answering the first question was easy. We knew we wanted to decrease the number of people diagnosed with late-stage lung cancer and increase lung cancer screening for those who were eligible. The second question was a little more difficult to answer, but our shared vision strategy grew from those early conversations and the commitments we made to root our work in county-level data for informed decision-making, to adapt and implement evidence-based interventions, to create targeted messaging and utilize a shared language that was clear, consistent, culturally appropriate, theory-based, and addressed low health literacy needs. We wanted to create sustainable change, so we nurtured relationships both inside and outside of the work group and coalition. We identified barriers and supported interventions that address the social determinants of health. We sought solutions that involved policies, systems, and environmental change, and grew opportunities to connect community members with clinical services. We also committed to measure the benefits of our activities and share best practices so that we could build lung cancer screening capacity statewide. Using these commitments as a guide, Mountains of Hope collaborated with a variety of partners to complete several key activities to promote lung cancer screening in West Virginia. We sought out projects that complemented, contributed to, or built upon the work of our partner organizations. This sharing of resources, research, and networks culminated into a multivariate implementation pilot project. In 2019, Mountains of Hope launched the project with 2 lung cancer screening facilities. The project focused on counties with high incidence of late-stage lung cancer diagnosis and recruited lung cancer screening facilities that could bill Medicare and Medicaid. We encouraged those facilities to then recruit primary care providers that were within 20 miles of the facility. The recruited facilities committed to holding a dedicated lung cancer screening event in November. The dates and duration of the events were malleable, but we encouraged them to schedule those screening events alongside the American Cancer Society's Great American Smokeout. Facilities then recruited nearby primary care providers and shared education and marketing resources provided by the work group. They completed program training, outcome reporting, and technical assistance as needed. The work group provided implementation toolkits for screening facilities and primary care providers, which contained provider and patient education, multimedia, co-branded marketing resources, and reporting forms. The toolkit also included the West Virginia Lung Cancer Care Line resource and encouraged the use of patient reminders for screening. In 2020, we added county smoking rates to our recruitment criteria and expanded the project to recruit 6 lung cancer screening facilities. We also refined the project by incorporating provider feedback to include onboarding sessions instead of training calls. And we replaced the CE video with compulsory lung cancer training sessions provided by the West Virginia Lung Cancer Project. And those who completed the virtual training received West Virginia Lung Cancer Project education and small media resources. Year 1 implementation increased lung cancer screening by 60%. And despite being in the middle of a COVID pandemic, Year 2 increased lung cancer screening by 30%. Year 2 also identified that 80% of current smokers screened were interested in smoking cessation at the time of screening. This project resulted in lung cancer screening facility and policy and protocol changes, such as targeted outreach to primary care providers by lung cancer screening facilities, the use of shared resources to implement lung cancer screening marketing strategies, changes to the electronic medical record reporting, review and evaluation of screening rates, expanded screening hours, and the establishment of referral, follow-up, and reporting procedures between the screening facilities and primary care providers. Additionally, one Year 2 facility provided a day of free lung cancer screening for uninsured patients to address health equity. This change alone increased screening for that facility by 21%. Some of the lessons learned were that screening facilities and primary care providers alike wanted more support for implementation, but felt that once the program was in place, it would be easily sustainable. And the data supports this, showing that facilities who participated in year 1 continued to increase screening over baseline in year 2, despite the impacts of COVID. The biggest motivator for both screening facilities and primary care providers was connecting patients to services. And all participants in year 2 identified patients' fear of COVID-19 infection as a barrier to screening. Many facilities were unable to host or join community events that would normally be large recruiting opportunities. But by far, the largest barrier was not having dedicated staff to help facilitate implementation. While Mountains of Hope can make these resources available, we don't currently have the funding or the staffing to maintain this project. But through the project, we learned how to effectively increase screening by building partnerships between screening facilities and local primary care providers. While this has been a major success, transportation continues to be a significant barrier to access lung cancer screening in West Virginia, and with good reason. Have you ever wondered why people in West Virginia tell you how far away something is in minutes instead of miles? Well, it's because a 30-day trip could take a 30-mile trip could take an hour or more, depending on which of these mountains you have to cross. The travel time required to access services exacerbates health inequities for our mostly rural population, especially with only a few lung cancer screening facilities that can bill Medicare and Medicaid. Unfortunately, this is not a problem the coalition had the capacity to address. However, a few years ago, the West Virginia University Cancer Institute, one of the founding members of Mountains of Hope, set out to add mobile lung cancer screening after looking at the success of their breast cancer screening program. They were able to use the data gathered from the Mountains of Hope lung cancer screening implementation projects to further demonstrate the need for this service. And after a long and involved process, the West Virginia University Cancer Institute is excited to announce that LUCAS, the Mobile Lung Cancer Screening Unit, is scheduled to launch this summer, with opportunities for future collaboration and support on the horizon. And it's through collaboration, innovation, and commitment to the shared vision strategy that Mountains of Hope and our partners continue to forge new paths to bring the hope of lung cancer screening to our greatest treasure, our people.
Hello, I'm Elizabeth Westbrook. I'm with the University of Louisville, Kentucky Cancer Program. I have no conflicts of interest that are relative to today's meeting. I want to thank each of our speakers for your presentations, and I would like to remind everyone in the audience that you can ask questions and comment by clicking on the Q&A button at the bottom right of your screen. We're going to moderate these questions and we'll get to as many of them as we can. So let's get started. Lawson, I'd like to start with you. There is a lot of stigma that surrounds injected drug use. Can you share some of the strategies that you used to build trust in a community that has quite a bit of stigma and fear associated with the needle exchange program?
That's a great question. The honest answer is looking at the population to deliver the service. We are an organization built with folks who have lived experience in a lot of the things that folks are going through. And so, you know, to me, the crux of good training and lived experience is really where magic happens. And being able to move in those spaces takes that, I think. You know, I can tell you what a rose smells like all day long, but until you bend over and smell it, you don't know exactly what the experience is. So folks can, you know, education and stigma reduction are good. But that lived experience quality of the service delivery, I think, is what allows us to move in those spaces with the trust that we do have.
Thank you. Dr. Jaya Prakash, what is the advice to those who are skeptical to go for colonoscopy examination based on the fact that a loved one or someone they know did not return alive after the procedure but died on either an examination table or had a punctured intestine when they were having a polyp removed?
That's a hard one, right? I mean, that's like deep fear in a patient, and how do you really overcome that? I think providing patients all screening options there are, helping them understand what the different screening options are and what they can do. Some that can be done in the convenience of their homes versus others like colonoscopy, which they have to go in. I think and really understanding where the fear is coming from and utilizing techniques like motivational interviewing to help understand and reiterate, okay, I see that you are having this fear because of this. There are several screening options, and helping them, this is something that cannot be addressed on one day and probably will take multiple visits to address. Let's say if this patient opts for a stool test, and if the stool test is abnormal, then they will still need a colonoscopy. So really taking more time than one visit to really address this, and using things like motivational interviewing to help understand and help patients see the value of it and overcome their fears.
Great response. We also had someone from the audience say the best test is one that they will do, and if they're not comfortable with a colonoscopy, suggest that they try a test that they are comfortable with. But as you pointed out, eventually they may go on to have a colonoscopy. But motivational interviewing and talking out about those fears is very important. Shelley, I couldn't help but think when you're talking about West Virginia, there are so many similarities to Kentucky. We have high poverty rates, heavy tobacco use, and high cancer incidence and mortality rates related to smoking. Our state was involved in a similar project to educate providers and communities about lung cancer screenings. And one thing that we kept hearing from people was, in a state like ours, where young people start smoking at a very early age and smoke more over their lifetime, shouldn't we start screening people earlier and lower the PAC rate guidelines for eligibility for screening? And wouldn't that allow us to catch cancers earlier? Well, in relationship to that, now that the United States Preventive Task Force has recommended new guidelines, how long do you think it will be before those guidelines are implemented? And when can we expect insurance companies to cover those guidelines?
That is always... Nix just keeps joining us to help fight cancer. It's her passion. It is always a little bit of a lag for insurance providers to come on board. And we have these new guidelines that are really exciting. And that's going to be very useful for, Appalachian and rural areas. So I'm excited about that coming up. And it gives us a little bit of time to be able to do education with our providers. So while we're doing that and getting them on board with the new guidelines, we have the ability to kind of use that time until the insurance companies come on board. And that'll probably be a couple years, I'd imagine, before they start really ramping that up.
All right. Thank you. We also had a comment for you, Shelley. This person says, as a mountain resident, I understand it can take 20 or 30 minutes just to get a few miles. Transportation is one of the largest barriers that we have for accessing many services. So she feels your pain.
That's true.
Yes.
And one of the things that Mountains of Hope has done, which is, we're the State Cancer Coalition, is if they want to check out the Cancer Resource Guide that's available through our website, there are resources on there for transportation.
Great. Good to know. This question is for Dr. Jaya Prakash. Do you believe the Illinois care system has the potential to thrive on Native American reservations where there are issues in lack of electricity, geographic distance of healthcare services, and health literacy?
Wow, great question. We pilot tested the initiative in urban setting because we heard that primary care providers in FQHC settings were hesitant to promote stool-based screenings because their uninsured patients didn't have anywhere to go for colonoscopies, even though located in an urban setting with a hospital nearby, right? I mean, even with that having, so it worked, and now we are expanding it. We are actually onboarding and training our rural partners currently in the southern part of our state. So having said that, I cannot speak for the rural communities, but we work with rural communities. We work with great rural partners. A lot of times the solutions come from them. We work with what existing solutions they have. We really harness their energy, their strategies, and make it work. I think our system really comes into play, especially when there are communication challenges between systems. When a clinic is able to schedule a colonoscopy appointment before the patient leaves, and there's a challenge with that, that's where our solution works. So I think similar to rural communities, I would say, I think understanding in addition to the challenges listed here, the challenges within the system interaction, I think understanding that will help us evaluate if the technology solution can be helpful.
Well, in relationship to that, was it difficult to convince healthcare systems to get on a portal with clinics to fill those spots?
So that's another great question. It can be, it's yes and no, really. I think the challenges really come when there are other changes in the healthcare environment. The challenges are mostly when there are mergers happening between hospital systems, which sort of delays in this initiation. That's when the challenges are. Usually hospital systems have some sort of charity care, and we really tap into that. We work with gastroenterologists who have a passion to address colorectal cancer disparities. And I think that really helps. And we work with existing networks that are already there. If there are no networks, then we build those networks. But I think it's a yes and no sort of. The challenges are mainly environmental. And sometimes, as we expand, we'll see more challenges. But I will say that especially in the rural part of our state, we've had very promising response from our hospital system. And that's very encouraging.
Okay, great. Thank you. Lawson, you talked about treating patients with hepatitis C. And how difficult is it to convince patients to complete those treatment regimens?
So, I mean, looking at there are different pieces of that have challenges. The first thing, period, is that people who use drugs do not enjoy going into clinical environments. They've learned from experience that sometimes even the clinics that have the best kind of information and education on reducing stigma still leave somebody going into a clinical environment with a bad taste in their mouth. So that's a huge step, just getting them into the treatment piece. The other thing is that for most of these folks, I'd say 52% of the folks we serve are unhoused. So most of the folks we work with wake up in the morning, and getting their Hep C meds or into a program isn't their first priority. And that's fair. And that's a big challenge there. The other piece is communication. Once we've initiated somebody into treatment, being able to try to do some case management is tough. Luckily, we have a community buy-in in the Roanoke Center, so we see folks often. But doing that in a rural setting where we've taken the clinic and done some testing becomes really problematic. And the other thing that makes completing treatment difficult is incarceration. We had 2 individuals who made it through their first 4 weeks and ended up incarcerated. So there are a number of issues that make it difficult to complete treatment. Transportation is another one. We've talked a lot about that in rural areas. That's why it's important, I think, when they talked about having a mobile screening clinic, and we have a mobile clinic to be able to go into those environments so we can reach folks where they are. But there are a number of structural barriers for somebody who we work with has to try to finish treatment.
Dr. Jayaprakash, what are some of the obstacles that you encountered when you did work with numerous health systems? And you were working with a lot of them.
And we're still working. I think I don't fully understand the question, because obstacles to use a technology solution, or
I guess just in implementing the program in general. So whatever obstacles you encountered
with health centers.
With health systems, yes.
With health systems, I think the obstacles can be viewed from 2 angles. One is with the community health centers, and the other is with the hospital systems. And I think the one thing with the hospital system, again, any environmental factors can be impeding, like mergers, acquisitions. I think at the community health center, I wouldn't really call it obstacles, but I think we know that community health centers a lot of times have competing priorities and can be understaffed, and they just have to play multiple roles. We work with so many health system staff where they're wearing multiple hats. They're administering COVID vaccines at the same time they're attending implementation meetings with us, and are also trying to call patients and remind them. They're directing the QI department. I think it's about staffing. Staffing plays a big role in being an obstacle to efficient implementation. That's probably one of the main things, for sure.
Okay.
And I think we can keep going on and on, but let me just stop here.
Thank you. Shelley, the Mountains of Hope Coalition has existed for over 20 years. How do you continue to keep partners engaged?
Well, I think some of it is the way that we structure things. When we write the cancer plan, we know that the coalition is going to work to see the aims and implement the strategies of that cancer plan. But who does what isn't something that we assigned. It's volunteers. So being able to self-select what you find as a priority and being able to align those priorities with the organizational goals and the passions of our members is, I think, the key. Because when that happens, you have this wonderful opportunity for everyone to try and help each other share resources and meet the goals that we have together. And it provides these fantastic moments of magic where this person needs something, this person has something, and when it comes together, it makes a whole new opportunity or shows us there's a new problem that needs addressed that we would have never thought of without having that slightly controlled, chaotic interactions.
Okay, I think we have time for just one more question. And Lawson, you spoke about 5 of the 12 people with Hep C who were successful in completing their treatment. What contributed to that success?
A lot of those folks had resources. Like I said, most of the folks we serve don't. And so that makes it really difficult. Those individuals had resources. They had places to go each day that they know they'd be safe. And so that's the difference, really. There are folks with resources versus those who are enforced, situations or they don't have it.
Okay, well, we could go on much longer, but unfortunately we have to wrap this up. So let me say thank you, Lawson Keppel, Dr. Manasi Jayaprakash, and Shelley Dusick for sharing your innovative approaches to detecting cancers early and participating in the discussion. Thank you to the audience for joining and for submitting questions. On behalf of the Prevent Cancer Foundation, I would like to thank all of our attendees and participants for taking part in the second webcast of the 2021 Dialogue for Action, the virtual Prevent Cancer Dialogue. Please respond to the satisfaction survey when you receive it in your email. I'd also like to take this opportunity to thank our generous sponsors, Exact Sciences, Grail, Bristol Myers Squibb, and Hologic. We appreciate you all tuning in, and I believe that if we have no more questions, that concludes our webcast for today. Again, it was a pleasure hearing the great work that you're doing, and we want to invite everyone to join in our next webcast, which will be June 2nd. So please be sure to join Prevent Cancer Foundation as we look at progress and challenges in cancer screening. You can go to the website, to the conference homepage to register for that. We hope you'll join us, and we hope that everyone will have a good rest of your day. Thank you so much.
Thank you.
Thank you.